All right, I'm going to go ahead and get started. Welcome, everyone, to part one of Leveraging EHR Systems for Language Access, Reach, and Compliance. I am so excited today to be hosting this webinar or moderating the webinar. As a fellow language access manager at a healthcare system, this is a topic that's near and dear to my heart. So I'm really jazzed about being here. Today, we also have a representative from Epic, the largest electronic health record or EHR platform. So that said, we are very interested in hearing from language access administrators who have experience with other EHRs like Cerner or Meditech or others. So please feel free to share your success stories. You can share them at OTR@NCIHC.org. And stay tuned for part two of our EHR conversation. We're definitely hoping to continue this because I guarantee you 90 minutes is not nearly enough. So today, of course, we are really looking forward to hearing from all of you about your experiences with EHR, regardless of which platform you use. The chat, as you can see, is open, but please use the Q&A for your questions. We have a lot of information to share, and we'll try to get to your questions as they come up. But definitely we'll be compiling those questions and continuing the conversation in part two. So before we jump in with your questions, let's go ahead and start with brief introductions from our panelists, who you are and what your position is and where you work. I guess I'll start by asking, I'm going to go in order of who's on my screen. So Andy, let's start with you.
Sure. My name's Andy Schweeder. I lead the language access team at Cincinnati Children's.
Fantastic. All right, Rosemary.
Hi, my name is Rosemary Ford. I'm the System Director of Interpreter Services for Covenant Healthcare Systems.
Thank you. Great, Caleb.
Hi, my name is Caleb White, and I'm a software developer here at Epic, and I work with our translation team and work with our community to help improve language access in our software.
Wonderful. And last but not least, Melina.
Hola, hello everyone. This is Melina Kolbach, Senior Director of Language Access Services at Children's Health of Dallas, Texas.
And I'll introduce myself as well. I'm Debbie Lesser. I'm the treasurer for NCIHC, and I also am Director of Language Access Services for a large healthcare system in Atlanta. So happy to be moderating today. All right, let's just jump right in. So I'm going to start off by asking a question about language service providers. So I'm going to direct this one to Caleb to begin with. Before I ask my question, though, I just want to say we all love our language access providers. Our language service providers. And I really, when you answer this question, I want you to kind of keep it LSP agnostic. So, so my question is that LSPs claim that they integrate with Epic, but do they really? Like, what exactly does that mean? So what does integration with Epic look like at this point, and what do you see coming, down the pipe in the future?
Great. Yeah, thanks so much. Pleased to be with you all this morning or afternoon, I guess, for some of you. Language service providers provide a really important role in providing broader access to more languages as well as around-the-clock services. So when it comes to functionality within Epic or thinking broadly within any EMR, I think trying to think through how to make it clear and obvious that an interpreter can be included or can help facilitate a conversation is the first step in terms of language documentation being in place. But when it comes to actually connecting with different providers of these services, there are a couple things available today, and then I'll mention how they might look down the road. Today on the interpreter side specifically, one of the primary areas that we have functionality available is in inviting an interpreter in for a video visit over telehealth, or using that same type of video functionality for a remote interpreter if both the clinician and the patient are in the same room, but you need to invite an interpreter in remotely. So from within Epic, there's an ability to see that the language documented for the patient is present, and invite an interpreter in on the language service provider, and they would receive a link to join that. And the key advantage here is that it provides an audit within the electronic medical record of the interpreter being involved in that interaction. So there's some documentation there available down the road. Along a similar line, right now that's primarily available through video, but we are working on certain cases to extend that to voice and audio through SIP as the standard. Yeah, we're excited to continue to make that more and more widely available and continue to see increased usage there, since that will help reduce duplicative documentation and needing to jump through various different tools in order to invite an interpreter in to facilitate that conversation. And then I'll switch over briefly to the written side for translation, because obviously Epic being a software system, we have a lot of written content that is meant to be shown to patients. Some of you are likely familiar with our patient portal called MyChart. It's often branded in different ways at different health systems, but that patient portal is available from a software standpoint in many different languages, Spanish, Arabic, simplified Chinese, Portuguese, and others. But the content from your organization isn't always available automatically in those same languages. So this is another area where you can partner with your language service providers if you need assistance in translating that content and pulling that corresponding translated version of that content into Epic so that patients have a more seamless experience. Along a similar line, patient instructions for a given condition, if they saw a clinician for a given diagnosis and there's some standard educational materials for a patient, there's functionality available to look at that patient's configured language and be able to provide the appropriate patient instructions in that preferred language. So identifying which instructions are most important, most commonly used, to make sure those are available in the languages of your population, and being able to export those, get them translated with your language service providers, and make sure they're available and being pulled in to be delivered to your patients is another opportunity.
Fantastic. Thank you so much. What a great way to start.
Yeah.
Do any of you have any experience with different kinds of integration, and anything that you want to add to Caleb's comments?
I can share that we don't use any of those interpreting integrations today. And that's mostly because we don't have microphones and speakers on all of our computers in clinical spaces. So using that as a workflow is kind of dicey when you can't hear what's going on in the room while you hear the interpreter. It's totally not going to work. But we have partnered with other companies that have Epic integrations that provide some of the written translation stuff. We work with an organization that provides like medication plans for patients that can pull medications from the chart so we know they're accurate and they have correct dosage, and then can display the instructions and when you take them in languages other than English. And that's all human translation. It's just pulling from a massive database of translated medication names, instructions, and dosages. And it can display a really nice bilingual medication table for patients and staff to review together.
That's great. That was one of my questions actually to follow up, Caleb, was all this translated material, like educational material you were talking about in Epic, does it still need to be vetted by a human's translator, or is it good enough to just take it straight out of Epic and send it to a patient?
Yeah, that's a great question. So The content that that we deliver as part of our software is vetted by translators, and so it's gone through that quality assurance process. And as you work through translating any content that you own within the system, I'd highly encourage making sure anything that you make available, it has already gone through those quality assurance processes before it's being incorporated. I think the piece to really wrap your head around is that if something is showing up in the software in a different language, being able to understand if it's actually that text was translated from the original source text and made available in that language, or if it's kind of being done automatically behind the scenes. So many of you are probably familiar with how a browser might suggest to translate something on the fly using machine translation tools, and that's not what's happening in terms of what's built in directly to the Epic software. It's actually been vetted, and we have the building blocks vetted so that they can fit together nicely and create a good user experience.
Debbie, if I may,
Sure.
touching into the integrations that Epic has done, that Caleb has explained, Children's uses Epic, and we are in the process of using the integration with telehealth. Now, talking about, it's going to be a process. There has to be some built up. As we know, our Epic department inside of Children has to work with the Epic team, and then also with the vendor who's going to provide the service. It has to be a vendor that has the integration also in place and is able to provide the service, right? So then, and just going back to the topic of this webinar, I think the challenge that is going to come to me is how is the provider then documenting that the interpreter was present via and just going with telehealth right now, and how it's being incorporated in the medical records for this patient. I just wanted to go back to that original question. I mean, comment that you had, or question that you had asked.
Yeah. Thank you. Great comment. I want to move on to the next question. That's a perfect segue to it. So, so can a language access leader or healthcare administrator, what can they do if the ready-made out-of-the-box EHR solution doesn't meet the organization's language access, documentation, delivery, and reporting needs? How do we improve that, or what do we ask for?
I can talk a little bit about this. When we went live with Epic, unfortunately, interpreter services was not part of any of the planning. So there was a lot of needs for the department. And because my team is phenomenal at keeping great statistics, that really captures the patient populations that we serve at each hospital, because of course it varies from location to location. That helped us immensely leverage our needs. We had the data available to show our patient populations, either folks who spoke certain languages, the percentages, disability populations, and by having that data available and also knowing about compliance and federal and state law, and having partnerships with key leadership such as risk management, legal, patient experience, these were all allies that helped us get what is called, at least at our organization, optimization in our Epic package, and have the build to better capture the demographic information of our patients.
Any other comments on that?
What Rosemary just mentioned is something that I wanted to emphasize during this webinar is who are your allies and how are you working or communicating with them? You gotta take advantage. What I have noticed in the language access services industry, some of us can be outgoing. I'm an outgoing person. I can talk to the wall and have a conversation. I'm not afraid of going to someone and just start a conversation and then somehow get myself into it. Like, for example, compliance. We do have compliance department. If I know that my documentation is really not up to par of the way that standards are being asked of us to do, well, find a way to have a friend in compliance, please. And then compliance, before you know it, they're going to be like, you're going to have a conversation about, okay, organization is really, the Joint Commission standards are asking for documentation. What are we doing about in the compliance department? We can't do everything. Language access cannot be owning everything when it comes to what federal regulations, the Joint Commission, CMC is asking of us. That's why we have, like what Rosemary said, we have the legal department. In my case, compliance and regulations. We have a risk assessment department. I'm using them. Just get yourself out there, please. You would not be able to do this by yourself. You have to be able to make connections and find a way, again, make friends within your organization. Go to meetings. Today I'm in a meeting and I'm about something else. It's about Lean Six Sigma, and I'm already looking in my table. Okay, who can I, start making connections that will then benefit our department? So anyway, I just wanted to mention that after what Rosemary had shared.
Absolutely, I think that's a really good point, Melina. That language is a component of every communication interaction with patients, with families, with the public. It's everywhere, and it's so much that we can't sit around and watch and be like, oh, you forgot about language, and you forgot about language, and you forgot about language. There's just too much. We're not going to be able to see it all. So instead, we have to work with our partners and leaders in the organization to get other people thinking about language when they're building a new project. At Cincinnati Children's, we love to do things for all patients. And my goal is that when people say all, it triggers their brain to be like, oh, wait a second. Not everybody speaks English. We have to do language too. And that we can build that in from the beginning so that we're not stuck like we so often are, like you were, Rosemary, where, oh, wait, there's a language piece. Maybe we should have planned for that. Like we should have known it was coming, but we didn't. So I think Melina's approach is spot on of a way to mitigate that.
And I'll add a brief note here too from my perspective. So people in your IT departments may feel that language services is just as foreign to you as their IT work is. Like, there's understanding on both sides. So I think building those bridges to figure out what's available and how to make it a win-win. I'd also just want to add briefly that whether you're using Epic or a different system, I'd recommend trying to figure out what has worked from those who are similar to you or using your systems, and replicate that success before you try to innovate to solve a brand new problem. We don't need to be inventing more types of wheels right now. We need to be using wheels that are there and trying to solve other problems in this space as we continue to try to advance as an industry.
Absolutely. Ensuring that you have the right stakeholders involved is so important, whether it's compliance or nursing services or risk management. All of them definitely need to be involved. And the more active we can be with that, the less likely we'll be forgotten when a new system is starting to be developed. So absolutely. So speaking of new systems, I'm going to move on to my next question. In my ideal world, all patients of every language receive information, educational information, or an AVS in their preferred language. So how do I avoid from starting from scratch every time? What's the best way to go about getting written information from an EMR? Are there templates? I've heard of smart phrases. Can you elaborate a little bit on that?
It's easy for me to speak about this subject just because we have a process in place with Epic. Again, I'm not being the commercial for Epic. Okay, we just happen to Epic. It has been very helpful. Two things have been helpful, and that's the one thing that I want to mention. I hope everybody goes ahead and finds out what is the standard of a discharge instruction in your hospital. There has to be a You're allowed to do this, you're not allowed to do that. We work with residents, we work with nurse practitioners, we work with doctors. Everybody seems to be doing something different, but I'm sure there's a standard. So there's a standard of how a discharge is supposed to be presented. You wanna, again, have a relationship with that committee or that person, or in our case, special education that has a standard. So that's number one, because once you know what is supposed to be expected of your hospital to give to a patient in English, that's already very helpful. Like, what's the standard? Once you have that in place, once you find out, hopefully there's a standard in your hospital or your clinic, and sometimes there's not, but for us, there are. For example, or discharge instructions, you may not add patient education. Patient education can be 2-3 pages. So patient education, in our case, is not allowed inside the discharge instruction, but it can be a handout. So that's what I'm gonna pass to, like, are your handouts, your commonly used patient education, are they already translated? So number one, work with your department, with your patient education department, or whoever is in charge of handouts for patient education. Have they been translated? If not, start working with them. Even if you're outsourcing that with an agency, have them translated and handy. So it's just a handout to provide. Inside of Epic, there's templates that you can use. Epic has some of these templates already translated. We like to have a human review them, to be honest with you, and then we customize that to our glossary. So although Epic has already some things pre-translated, we go ahead and have our Epic team do a translation according to our glossary and the way we want to say things, because we work with children. So child can be translated in so many different things in Spanish. So that's number one. And then, yes, there are many things that you can already have pre-translated as a smart phrase. Working with smart phrases or text phrases, working with that, having already pre-translated things, if it's a discharge instruction of 2 pages, you can actually get it done within 20 minutes. And just because you have a standard of how this is being translated, again, it's not always going to work like that. You're going to have residents, physicians, or other part of the team who's going to like to customize things, and then you have to go word by word. But I hope that provides some insight to that question.
Anybody else want to add to that?
I can add briefly. One area that I think comes up pretty often in this space is figuring out a plan when it comes to using that MyChart patient portal to facilitate the communication between patients and providers, or even caregivers like a parent. There are organizations out there who are doing really great work with being able to detect the language there and automatically route it to a pool of translators within their organization to provide that translation and facilitate that communication on very similar timeframes as if a message was submitted in English. So thinking through, it's possible today, and how do we continue as an industry to make that easier and easier? And one of the challenges, I think, is that there's not necessarily enough work for a health system to hire translators for all of the languages that they serve full time, and balancing that need for very quick turnaround on certain types of translation work, even if it's just a paragraph, because many of these MyChart messages are 3 or 4 sentences, but it's a valid question of, like, do I need to be worried? Should I come in for a visit? And the content there is really key for patients getting care early and preventing further problems. So yeah, I think that's a joint challenge that we have in terms of making it even better and better. I know there are organizations exploring partnering up with a language service provider to give limited access to just those messages for translation purposes, with appropriate security protocols in place, so that they can turn those around more directly, even with translators that are not their direct staff. So I'll be really curious to see how that goes, and hopefully there will be more success stories to share on that front too.
Mm-hmm. Does Epic or EHRs in general, do they help us with tracking readmission rates? That's one of the questions from the chat. Readmission rates of diverse patients, they tend to be 2 to 3 times higher than those of non-English speaking patients. So does an EHR help me determine those readmission rates?
Yeah, the short answer is yes. There's a lot that's possible, whether that's readmission rates or other risk factors or outcomes that need to be tracked. I'd highly recommend working with your making that friend in IT, like Melina mentioned, to learn more in that space. But Slicer Dicer is one of the tools that we have that's available for more of that self-service reporting, that if you work at an organization that uses Epic, you might have access to some of those types of metrics and also be able to filter by language at the same time. So you might even have access, if you're part of an Epic organization, to do some of that exploration yourself.
And that was actually one of the comments that one of the panelists had made earlier, was that before we actually started the webinar. So I'll tell you what was said. And it was that a lot of times we as language access managers will ask for something and are told, no, Epic doesn't provide that, or no, that's not something you as a manager are allowed to do within Epic. Have any of you experienced that within your system, where you've been told, no, Epic doesn't do that? And how have you responded?
Epic usually can do it. It's the hospital internal Epic team that might not have the priority or the time to do it. I have had meetings with other hospitals that have worked with Epic. We show them how we manage not only documentation inside of Epic, but also how we manage assignation of encounters to interpreters within the hospital. And then they want to duplicate and then go to their Epic team in their hospital. And the answer has been, it's not a priority. We require a bigger group of Epic experts to do it because it has to be built. So that has been more not the issue, but I guess the barrier. We are a support department. We're not clinical. We're not making money for the hospital. Although we're compliant, you can be smart how you use that, because we are a regulatory program. So again, if you know how to use that leverage, you will probably get more traction for them to look at your processes if you're not being compliant. But it's more about, do they have enough bodies in the Epic team to work on your project?
Mm-hmm. Mm-hmm. And I'll just,
thank you.
If I could speak briefly to that comment, Melina, too, that is an area that Epic broadly is trying to focus on more as well, in terms of making it easier to maintain and support your goals as an organization through the configuration of Epic. One of Epic's strengths is all of the building blocks within it that can be put together in very creative and powerful ways. But that sometimes means you also need the Lego instructions to be able to build that. And thinking about how we continue to improve in that area is definitely an area I'd encourage you all to work with your Epic counterparts to share that feedback and that challenge.
Thank you. This made me think about best practices. So what can language access leaders and healthcare administrators do to seek out best practices with regard to EHR customization and just general usage within language access? And I guess this is for all the panelists, of course. So what have you done as far as best practices, and have you found any resources that elaborate on best practices?
When I've been at Children's since 2015, when I came to Children's, I realized that we were doing too much documentation, actually.
Much. I didn't know saying is too much.
Yes. So we have a system where the interpreter gets assigned to an encounter via an Epic order. So this Epic order, it's already added to the patient chart, and it has basically all you need. If you look at the regulations and description or standards that are being asked for me as a hospital to have documentation, they don't tell you much. They just said documentation. Documentation can be different to me than to Andrew, then to Rosemary. I heard Andrew say, hey, I require my interpreters to document A, B, C, and D. I don't need them. Like, I don't need A, B, C, and D. I might just need A, B. They're just asking for documentation. So I think best practices means what's important to you as an organization to be documented. Okay. So next to me, I have Parkland and UT Southwestern. I can ask them, and their best practices of documentation actually is very different to ours. We have been audited 3 times since my time here in Children's, and so far the documentation has been sufficient. So I think when it comes to that, it depends on the leader and what they feel is important to be documented as to best practice for the hospital. That's my point of view.
And I can add to this as well. I think when it comes to the documentation of language, there are recommendations available, and I can drop some links in the chat. So the Health Equity Roadmap by the American Hospital Association clearly, outlines what good documentation would look like in an electronic health record, as well as CMS, the Centers of Medicaid and Medicare. And when it comes to documenting for individuals with disabilities, there is regulation in place. So each state has different language access laws and communication access laws. So you should be very familiar with the state where your hospital is, or your healthcare entity is, and also be well versed in federal regulations. So Section 1557 of the Affordable Care Act does have very specific documentation requirements for individuals with disabilities. So you might be thinking of a physical disability, but also think about language access for our deaf and hard of hearing patients and companions who use American Sign Language to communicate. And probably one of the best resources that I've found that has so much information is the Disability Equity Collaborative. Soup to nuts, they'll show you everything that you need to have best practice and within compliance.
Fabulous resource. Will you put links to that in the chat for us?
Yes.
Fantastic. Great. Okay, so the next question I have, actually, I'm going to pull one from the chart, or from the chat, the Q&A rather. The question, I just lost it, was about captioning in video visits. Is captioning available in Epic or any other EHR when it comes to these telehealth video visits?
I can tell you what I know, and I know that it's been an area of that we has not supported in the past. We don't have captioning as far as I know, but there may be other experts at Epic who know that more specifically. I know it is an area that can help people follow along better and is a helpful tool, but it has its limitations as well.
We don't use Epic for our video visits, so this is not EHR integrated, but we have brought CART providers into telehealth visits. We use Microsoft Teams for that. I believe it's also possible on Zoom. So other telehealth platforms may have that option. My biggest challenge in that space is that I can't find any on-demand CART providers. It all needs to be scheduled in advance, which is okay for some situations, but can be complicated. Say if CART's the best way to communicate with an inpatient, it can be hard to tell when we're going to communicate. So scheduling is not awesome. I really wish there was an on-demand CART service. I think a lot of people would benefit from it if it was available.
Yeah. Any other comments on that? So I'm going to bring up another issue that tends to not be something that's integrated a lot. I've noticed that that documents will be translated like discharge summaries, but medication instructions are left in English. How have you all dealt with that?
I'm tackling that puzzle now. Our outpatient pharmacy does use Epic's pharmacy capabilities. and it is possible there to translate medication labels into other languages. However, the interface isn't super awesome. I can't easily provide feedback to the prescribing clinician of which instructions would get translation and which ones wouldn't. So there's definitely a lot of room to be gained there. We're able to go back and look and say, what are all the instructions that were used in the past year? How many times were they used? Translate the ones that were used more often. But it's still a little bit tough. Now, I think in our particular use case for our outpatient pharmacy, our pharmacists are going to call the doctor if they think they could make a small change to the instructions, and then there would be a translation. But it's very much a human intervention workflow there. So I'd agree that it's definitely still a challenge, at least for us and the way we approach prescription labels.
Inside the EPIC team in Children's Health, they were able to create what we call a translation navigator. That's the name that it was given for us, for my team, and the medications are included. What's really, we have established a process that, well, it's actually a system-wide process. The discharge instructions may not be released to the patient unless either the resident or whoever is doing the discharging, the clinical provider, they have done something that we call medication reconciliation. So, which means they review the listed medications in the discharge instructions, right? They review and they make sure that it's once a day, twice a day, they remove whatever is not supposed to be taken, and so on. Unless that has been checked as medication reconciliation has been approved or has been done, then we can touch or not touch the discharge instruction. And then once inside the template, we have the capability to translate the medications as well. Again, I think we have advanced a lot in that process. We're able to do that, but I understand what Andy's saying. And sometimes there's discrepancy what the discharge instruction is saying to what the pharmacy gets and what they translate. But thank goodness, at least we have the process that unless you know that the discharge provider has checked the medications, don't translate, don't touch it until that has been done, if you're able to do that in your organization.
And then are you also able to get the translations onto the medication labels that your outpatient pharmacy dispenses?
No, sir. That's a different step. That will be a pharmacy step. Yes, and we just transitioned to the EPIC. We just integrated the pharmacy with an EPIC solution as well. So I have to make sure that the 6 have been translated in the way that we want them as well.
Yep, and I think a lot of commercial pharmacies do this, but even there at least historically have been challenges. I was speaking with a retired pharmacist about it, and she shared that their system could print the medication label in a language other than English, but she was required to verify that the label was correct. And how could she do that if it's not in English? So for her, she just never used the functionality, even when it was there, and instead explained verbally with a phone interpreter what the medications were for. But clearly that's not as effective as having a medication label in the person's preferred language that they and anyone else can read later.
And I believe the translation of how to take a prescription is vital. So we should be translating that. It's part of the vital group of documents.
I'll speak briefly to current state in terms of what's possible with EPIC here. Like Andy said, there are so many different combinations of instructions that can be given, and the current state helps you prioritize those based off of which ones are most common. So you can choose to translate wherever you decide to draw the line. But yeah, long-term, we want to make sure that medication instructions are as simple and straightforward in English and in other languages too, because there's room for improvement in the English as well. And so there's a project in progress in that space that's aiming to make that more sustainable and more automatic behind the scenes, but it's still a ways out. So I wouldn't hold your breath right now.
Okay, so moving on to, I'm trying to decide which question to ask next because there's just so many. Let's talk about orders. So do any of you use Epic to place a consult or an order for an interpreter? And how does that work within your system?
I do. Oh, sorry.
Oh, Rosemary. No, go ahead. Rosemary, you go ahead.
Yeah, so with our Epic build, every time a patient is scheduled for an encounter, number one question they're asked is preferred language. Number two question is, does the person need a spoken language interpreter, yes or no? Does the patient need a ASL interpreter, yes or no? And then we have a fourth question that asks, is there an accommodation that is needed for this patient? So where we list of an array of auxiliary aids and services that we can offer patients and companions. As soon as the patient service rep, whoever's registering the patient, clicks yes, that is linked to a work queue that goes to our interpreter services department and alerts the scheduler for interpreting or accommodations that there is an encounter that will be happening where there's an accommodation for communication access needed. So that's been set up since the get-go. It works beautifully. And the key part of this is people need to say yes. Yes, an interpreter is needed, or yes, an accommodation is needed. If they do not click that and they say no, the request never goes to our work queue. So somebody wrote in the chat before, train, and when they're comfortable, train some more. Amen to that. So training is such a key component, and I'm a big fan of making things a no-brainer. So when we went live with Epic, we worked with the Epic team and the interpreter services team to build screenshots to put arrows like click here and don't do this, because in our particular build, we found that, people get really smart with using the Appointment Central application, and they find workarounds. So if a patient is being seen on multiple occasions, for example, in a rehab setting, they can copy and paste an encounter. Well, that means we're not going to get the interpreter request. So these are all kind of lessons learned, but we made templates and training guides for each department. And we make sure that, we're not wagging a finger at people, but we're working with them to see how can we make this easier for them, and how can we make sure that we're meeting each patient's communication needs in an effective way.
We do have the availability, or that's our system. We work on demand with Epic orders. So if somebody is ready to do roundings with a patient in oncology, and they have 2 or 3 patients that are Spanish preferred, oops, I hope you didn't hear that. They do have to place an Epic order, and then we have like a grab and go system with a group of interpreters, and then grab and go. That's how then it helps in our documentation. It's already in that patient chart, and you have the name of the interpreter, what time they check in, what time they check out, which was the provider. So there's a lot of documentation already in place. It did take a lot of work from the Epic team at Children's when we purchased Epic, and that was actually before my time. What I wanted to say though is that it might be a hard task for many of you who are already working with Epic, but I want to recommend the following. Transportation services, they probably already use Epic to get an order to pick up a patient from room A into, I don't know, to go into X-ray. So if you don't want to reinvent the box, if you want to use that, find out what your transportation department is doing. Social workers, I'm sure social workers use Epic to go from patient A to B. So again, if you're not finding the traction of the interest of your Epic team in your hospital organization to set up a system like ours, there's probably already something in place for those other departments that are using it. So go that route for now until you find the ideal way.
Yeah, I think the newly improved logistics and transport module in Epic is a great example of what you're describing, Melina, right? So it's primarily an evolution of a system that was built around patient transport, but now has much more flexibility. So we just started using that for our on-demand in-person interpreting requests a month ago. And it's the same system that is used for patient transport. We also use it for some environmental services tasks. And so the benefit here for us was that a bunch of people already knew where the button was, right? It's like, oh yeah, now there's interpreter in the same menu. Cool, I can do that. We had a lot of conversations where we expected a big training need, and they were like, oh, it says interpreter. Great, thanks, bye. So I think that there's a huge benefit of building on those existing systems. So at least for us, we have a couple high volume areas where we are able to use this on-demand request, right? So if you want an in-person Spanish interpreter, ask when you're ready. Sorry, I'm not scheduling it in advance. You ask when you're ready. And this really cuts down on patient no-shows or on the interpreter having to leave because they have another scheduled appointment somewhere else, both of which are pretty bad experiences for everybody. That being said, we don't have enough volume of all languages or at all locations for that process to be effective. So we do still schedule in-person interpreters for other languages or at other places through a process we've been using for more than 10 years. And that's assigning the interpreter as a secondary provider to an outpatient encounter. And if the need's not an outpatient encounter, we make a fake outpatient encounter, and then we can assign the interpreter as a provider.
So by you using the logistics system, then how are you documenting that the encounter has been completed with an interpreter?
So there's not.
Sorry, Debbie.
No, that's great. Thank you.
I think that interpreter documentation manually by staff is not a very effective approach. We've not been able to get very high compliance rates by expecting someone on the clinical side to perform manual documentation tasks.
Right.
We've tried that for many years and have not gotten very far.
Mm-hmm.
So we're exploring alternate approaches to that. Right now, if there were a interpreting event through logistics and we needed to know if it happened, we have all the logs from logistics. Now, that doesn't mean that it's easy to see from the patient's chart review. However, if we have a question about was an interpreter present for this patient, I can look that up. And I think we're looking to go in that direction even more broadly. I think we want to try collecting patient medical record number, date, and time, and using those three factors to tie it back to encounters and effectively keep a separate database of interpreting interactions as opposed to always trying to get a sentence or two somewhere in the chart. I think with that approach, we're going to get a lot higher compliance rate, and I'm going to be able to actually understand what's going on in our system. That being said, manual documentation with a hard stop has seen some success. I think Vanessa already shouted in the chat what they did at Cambridge Health Alliance. And with outpatient encounters, they were able to put a hard stop in place and force clinicians to document how they provided access. They have very high compliance rates, very reliable data, and were able to provide education to the clinicians that needed it.
Kudos to Vanessa. We were not able to do a hard stop. You get,
Yeah. If I can maybe just take a quick sidetrack here to share a success story in this space. I think Hennepin Healthcare in Minneapolis has done some really incredible work in this space for using Epic to improve their language services delivery and their documentation. And they've used many of these strategies for many years now, I think nearing 10 or more years. And some of what they've done lines up with what Andy described with that logistics module, but their clinicians can submit that request for an in-person interpreter directly in Epic. So it's easy, it's very clear to them where they need to do that, and they understand the rough expectations for how far in advance or how much time there is to wait. And then interpreters at their main campus are dispatched in real time, factoring in the acuity of the situation so that they can prioritize appropriately to the most urgent needs. And then their own on-staff interpreters document that time spent interpreting in the patient chart And one of the reasons they do this is also to then be able to get reimbursed for some of the work that they're doing. So they've worked over the years with their payers and state legislative representatives to increase those opportunities for reimbursement for interpreter services. And they actually drop charges within Epic because Epic has that functionality for dropping charges related to different interactions, so that those payers can then receive the necessary details so they can get reimbursed. So kind of brings it back a bit full circle. But then, like Andy said, in person for your own staff isn't going to handle everything. So they meticulously scour the schedule for languages that won't be able to provide in-person services, or where over the phone or video really isn't going to be effective, such as for an audiology scenario. And they work to get third-party interpreters for any of those that are, can be planned for, and then fall back to a very robust video and phone-based interpreter services as well. So I think it's just a neat success story to explain the hybrid use of in-person and third-party, but also keeping it as accessible within Epic for those clinicians, but that the clinicians also know that if they are faced with an immediate situation, they can use those third-party voice or video solutions too.
Excellent. So talking about documentation and getting compliance around that, do I have to use the interpreter flow sheet? Or can, for me, it's frustrating when clinicians nurses will just put a note in the chart. It's like trying to find a needle in a haystack to determine whether or not an interpreter was used. So any success stories around the use of flow sheets, or like you were saying, Andy, I think it was Andy that you had said that if you add an interpreter as a secondary provider, then you don't have to worry about documentation at all. Can you elaborate on that again a little more?
And that's our scheduling process. I don't think that it's super robust from a documentation standpoint. If the interpreter for some reason doesn't make it, they probably don't get removed as a secondary provider from the appointment. So I don't know that I would trust that as confirmation that the interpreter was absolutely there. We have flow sheets, but because there's not a hard stop, they don't always get completed. And that's why I think we're looking to move to that MRN-based documentation system, where when you work with an interpreter, you provide the patient's MRN. That, along with the date and time, which I'm already getting for billing purposes, allows me to map it back to a patient encounter.
I have a true story to share. We had a mock survey. I think it was before COVID. I think it was 2020 or something like that. So we have a mock survey, and we have the consultants looking for interpretation documentation. And this consultant was actually pleased with finding some sort of documentation by the provider inside their charting. Debbie, like you said, I don't know why they were pleased, because you have to go through all of the summary of, the charting of the provider. And then at the end, by the way, this interpretation was provided. Sometimes they put translator, but this interpretation was provided by such and such, and then the number of ID. So I was actually surprised that the consultant, and this was for Joint Commission, she was actually okay with that. She was like, hey, as long as there's some sort of documentation, I don't care where it is, but it has to be. Because again, although there might be some standards by state and so on, and the states or regulatory needs, they're not very specific. Sometimes they're not as specific. But she was happy to find it inside the chart. However, later on, the compliance and regulatory team in my hospital made it an expectation that if you are a clinician and you use phone, video, or even in person, a vendor in person, you have to document via flow sheet. We just had a survey, a real one, last week. We were all very nervous. They came in and they had a nurse navigate a patient chart. And luckily, I guess we're being more compliant than what I thought. Again, this is how you have your relationship with other departments, in this case, compliance and regulations. We didn't get any red flags, so we didn't get any penalties. That we passed. And they're looking more and more about how we're documenting and how we're using interpreter services. Just FYI, I was surprised to see how interested they were to look at language access, which in the previous surveys, they didn't. But I can't remember the question. But anyway, I hope that helps.
Absolutely. Fantastic. Yeah. And the question was just about documentation. What are your success stories around that? If you guys are okay with it, I kind of want to pivot a little bit and talk about AI because that's such a hot topic right now. What opportunities do you see for artificial intelligence or machine translation to help improve communication with patients in their preferred language in the future?
I can kick us off. Oh, do you want to go ahead? Okay, I'll kick us off briefly, but I'm sure we can talk about this for a while if we want to. Speaking just more generally, I think actually like language services has been dealing with AI longer than kind of the broader public in many ways. We've kind of, Google Translate as a concept has been out there for a while. But it's great to be thinking just generally how are these if used effectively, because healthcare is a very, very high stakes context for these types of new tools. So just at Epic, generally, as we think about AI projects, we want to make sure we're focused on safety, on transparency, being clear about where AI is being used, and ethics as well. There are important considerations around equity and showing respect to individuals and different things like that. There's obviously a regulatory component as well in terms of, like, I think the regulatory component is meant to reflect a lot of those same three factors of safety, transparency, and ethics. So as we learn more about what is safe and how we can be transparent, I'm hopeful that down the road we can find those cases that are useful and valuable and more efficient and cost effective to allow machine translation to supplement the work that's being done today. And I think I can say this since I'm not working directly with a healthcare organization. Machine translation is being used by both clinicians and patients out there. I've seen it firsthand in many cases where a message comes in and it gets put into a third-party public machine translation tool, and people may be evaluating what they think they understand from just purely looking at the result from machine translation tool without full awareness of the risks of the sensitivity of information they're putting out there into a tool like that. So I think, and on the patient side as well, like I mentioned earlier, that browser functionality is actually pretty aggressive almost these days to say if your browser preferred language is something else, like Spanish or Portuguese, and you go to a website that's not declaring that it's in Spanish or Portuguese, it'll prompt you of saying, hey, should we translate this one for you? And you can accidentally click yes if you're not paying attention to it. So I think figuring out how do we evaluate this more holistically and help let computers do what they're good at in a way that's safe, but let people do what they're especially good at too, will be a neat challenge. And that more real-time communication we talked about earlier on in the call will be really key, as well as machine translation can help accelerate and kind of make things more efficient too. One of the ideas in this space that I think would be fascinating is if you had a way to facilitate a conversation between a patient and a clinician, and more like introduce the machine translation as a third party in it, as a chatbot of sorts that's facilitating the translation so that the user experience would be clear and there would be a very clearly communicated escalation path to pull a human translator into the loop. I'd be really fascinated to see that down the road. But obviously, we have to do that all in the context of those three areas of safety, transparency, and ethics being our foundation.
And PHI.
Yes.
So I don't know if Andy or Rosemary had something to say about that, but I have been working on these for 2 years, a little bit of AI in terms of machine translation. I think it's already here. Many people are already using it, the machine translation. We just, like Andy said, we just don't know. It's not being disclosed. It's a dangerous thing, especially if you are interacting with something outside your organization, working in the cloud, and you have PHI, so you have to be very careful with that, because you're not supposed to be doing that unless you have a business associate agreement in place. So anyway, I'm saying a lot, but I do see it being a part of our translation and sooner than interpretation, for sure. If not, like I said, it's already here. Like what I'm finding the challenge that I have been finding, or that I have already found, is that we can integrate artificial intelligence with machine translation inside of Epic. The issue has been finding a vendor agency that is willing to sign a business associate agreement, taking full responsibility if PHI gets leaked. So when you find a software company, at least for children's or business associate agreement, it's pretty detailed. It's asking for a high amount of liability insurance in case PHI gets leaked, because you're not working on site, you're not working on your platform, you're working in the cloud. So it's leaving, right? It's coming from Epic into their machine translation and coming back. But anyway, that's one issue that we're working on. You think every agency is going to tell you, oh yeah, I can sign your business associate agreement. Once they see it and how it works, then they're like, nope, our legal department will not sign that because it's a huge liability. So moving from that, you can use it on site, I guess, if you are able to find a good software that can help you without having to leave the organization, going to the cloud and doing the translation. But if you find someone, let me know. I agency that is willing to do it and take full responsibility of any PHI being out there or lost. Yes, let us know. And also, they have to work on the connector, Caleb, as you are imagine. How can they make I think that's an API, right? I think that's an API.
Yep.
A lot of technical terms for that to leave Epic, go translate it and come back. So that's another topic.
And then, Melina, wouldn't you still need a human translator to review that?
Apologies. Yes, absolutely. So where I was going with this is I don't know about your organizations, but for example, for us, we always have children waiting to get a bed. So one of the initiatives that the hospital has is that once the patient is ready to go home, the provider has signed the discharge. Within an hour, we want this patient out, because we have some of them waiting in the emergency department or another area waiting for a bed. So absolutely. So AI would be a huge advantage for us. Imagine getting translated automatically. There's already memory translation. It comes back maybe within 5 minutes, probably less. And then you have to have a human review the translation. Medication reconciliation has been done. It's according to us, everything is fine. And then absolutely it goes out. And on section 5057, the recommendations are that some of the proposed ruling is that, yes, hospitals, we can use machine translation, but it has to be reviewed by a human. I do believe they haven't been approved yet.
Yeah, I think that review by a human is currently required for any organization receiving federal funding for healthcare, and is a really non-trivial step. If the machine translation is long, how long is it going to take a human to review it? I personally find that automatic translations often make mistakes that humans miss. Most of the translation is good. It lulls the human reviewer into thinking it's all good, and mistakes slip by. I had a human translation that we were reviewing. We had like 5 or 6 people looking at it because it was like slightly sensitive. And there was a part that was less sensitive that was a dosing table for ibuprofen. And it said that the dosage was according to weight. And then down below it said 0 to 6 months, 1 to 2 years, 5 to 6 years. It's like, wait a second, this isn't weight, this is age. Like, what? Yeah, sure enough, mistranslation. It was supposed to be dosages according to age. and that slipped by everybody. I've had wrong patient name slip by people before. I had a medication number get multiplied by 10 because the decimal point was in the wrong place that people didn't notice. So I think there's a lot of risk around this, but there's risk around human translation. All those pieces I described were human translation sides of things. So what I'm excited to see is when we get into more accurate error estimation and those sorts of technologies around AI to help us feel that this translation is similar to a human translation in terms of what sorts of errors are we going to see, what is the error rate going to be. But until we get there, I don't think that it's going to be safe or even all that helpful for use in healthcare. And the one last point I want to highlight is that I think we can maybe get there for Spanish. But as we start talking about other languages that we see, your quality is going to drop rapidly as the amount of resources goes down rapidly, at least looking at current technologies. And I think the ability to even assess those or to have that human who can review the translation becomes much, much harder. So I don't know. I see promise. I see some hope, especially around Spanish, but I don't think it's going to be a panacea. I think there's going to be a lot of need for human translation and alternate processes, ways that we can communicate this information verbally with a qualified interpreter or find other ways to communicate that don't require rapid translation for in any language under the sun.
One of the questions in the Q&A was whether Epic relies on language access experts to develop the platform. So how we, some of the smart phrases, for example, that are available in Epic. How do EHRs come up with that? Are you working with human translators and interpreters?
Yeah, so we are working with translators closely in many of those pieces, and sometimes it's coming from the Epic software, and sometimes it could be content within your system. It's often difficult to tell those apart, but we actually have health systems in Switzerland, the Netherlands, Finland, Denmark, in lots of different languages. So when we're talking here in this webinar primarily about the patient-facing communication, but we've needed to handle the broader internationalization of our software even at a higher global scale. So we do, it's a very important part of our development process to make sure that we're thoughtfully using appropriate localization strategies, internationalization strategies to deliver a good experience.
So even from an EHR standpoint, you're really collaborating both, you're blending, I guess, both AI and human translation and interpretation tools.
Well, what I was saying there was just generally about software development practices, but we have translators who work with providing those translations that are part of our software. So yeah, we have done some experimentation with different AI translation models and have seen some good results and also some of those types of mistakes that Andy mentioned. But yeah, we have translators involved in that process.
And how many languages are available in Epic?
That's a great question. So we have a handful of different areas. In the MyChart patient portal, we have 12 languages today. And then in our after visit summaries and Hello World kind of SMS messaging, that's a little bit of a newer area. We have 14 languages. So that includes all of those MyChart languages plus Tagalog, Vietnamese, and Russian. And then for Welcome, which is our kiosk for checking in and for, urgent care or different things like that, we have 22 languages available.
Could I add to the language question? From my experience, when we got our Epic language list, I found some redundancy in the language list, and there were gaps that didn't necessarily reflect our patient population. And Yes, at first I was told it couldn't be modified, but guess what? It could be. So when I say some redundancies, for example, I would see American Sign Language, then sign language listed, or I would see traditional versus simplified Chinese, but then also Cantonese and Mandarin would be listed. So what are we going with? Which one? So that was a decision that I made as to which languages we would keep, because I report out on what is our language diversity, what does it consist of, and plus it just confuses folks as well. And one of our healthcare systems is a refugee resettlement area. So there were lots of gaps in the language list. And I don't know about everyone here, but I think we probably could agree that we hate when we see other listed as a patient language. So of course, not only is it frustrating, but it's a patient safety issue, right? We need to be able to properly identify what language our patients speak and have that available, because once it becomes part of their electronic medical record, it follows them. And we don't want to be delaying care because we have other listed. So I would just say be persistent and be able to articulate why it is so important to have the right languages listed, and know what your patient population consists of.
Yeah, excellent. One other causes so many problems when it comes to language access, and one of them is delaying care, because you have to go back and documenting things inaccurately. Preferred language in Epic. In my healthcare system, for example, the second most common language that's marked yes, we need an interpreter is English. So, and clearly, there's a lot of inaccuracies there, though. So we need any suggestions on how to clean that up, because your data, when you're collecting as a language access manager, is only as good as the documentation in Epic. So any suggestions on how to encourage your team, whether it's registration or nursing, how to document more accurately, and if they don't know what the language is that a patient speaks, is there any other option besides clicking other?
That's a great question. I think that scripting the language for staff can go a really long way in getting the question asked correctly. There's been published research around this where they've experimented with, how do we ask the question? What kind of answers does that get you? And most of it points to asking people what language they want to communicate in, as opposed to, do you need an interpreter? For us, since we're a pediatric hospital, it's a little more complicated, because we're not just talking about one person's preference. We need to understand the family's needs. So the questions we're trying to ask are something like, do any of you all speak languages other than English? And if they say yes, what languages do you want to communicate? What languages do you all want to communicate with us today? As you can see, I stumble over it here. So having this scripted in Epic right by where people answer the question can go a really long way in getting it asked consistently. There was also work done at Children's Hospital of Philadelphia at putting this into triage in the ED, where they're already reading question after question after question. And so this really fits nicely into that workflow of scripted questions. But if you're able to do that and you ask every patient every time, over time your data will become more accurate. And if the patient can't answer your question about what language they speak, you're going to need to bring in an interpreter to continue the conversation anyway. So I think you're going to have to solve that problem one way or another. Language identification cards are great. One thing a lot of people don't realize, though, is that phone interpreting companies have operators who can also help you with language identification. So if you call them and you get the operator on and you say, hey, I have a person here, I don't know what language they speak, can you help me? They can absolutely do that for you.
I have seen the health equity department. So if you have a health equity department, push for that. And again, it's all about connections and who you partner with. The health equity department will probably help you find a way of, we call them ASRs, ambulatory service reps, the staff up front who's asking these questions. Like Andy was saying, sometimes they don't know how to ask. They're afraid of asking. Some people don't like to be asked, and they have to, because they have to fill out those questions. So if you can find a way of getting the attention of United Health Equity team, they will probably help you. It's gonna have to be a manual process of when, and maybe by clinics, when patients are coming back, revisiting those questions and making sure they have the right information in patient demographics. But again, Health Equity has been a good partner for me to push for this, so patient demographics get the real data. And again, it's a manual process.
Okay, so I'm going to go back to some questions from the Q&A. I'm going to combine two questions basically here. So one question is about the after visit summary translations. Is there any way, do you have a process in place for AVS translation that helps patients get that translated material in a timely manner? And are there any, does Epic have any machine translation software that is currently accessible to us, or that maybe is integrated with Epic that can help with things like AVS and getting materials to patients in a timely manner?
So I can start because I have a I have a less sophisticated answer than Melina and Caleb. So I think we should move up in better process here. We had a researcher really interested in improving this on one of our units a few years ago. We did publish a paper about exactly what we did, which I can drop in the chat again for us all here. Basically, we have smart text that is a bilingual table of discharge instruction for common diagnoses. So it's already there. It's easy to build this without any special configuration. I mean, as far as the system's concerned, it's just text. And so it's really simple to get that set up on a small scale for specific units, for specific diagnoses. The big challenge though, you have to work with clinicians to modify the regular instructions so that they'll work for everybody, because they're not going to be able to customize the translation for the individual patient. So we did that, and we built a workflow where you can request translation of anything you made. But of course, that takes time because we have to send it to human translators and get it back. Maybe if it's Spanish, we'll get it back today, but it's already late afternoon. Maybe it'll have to be tomorrow. And for other languages, we almost certainly need probably until tomorrow most of the time. And that's not great. It works well in some units where you can predict discharges, but it doesn't work well in others where people are coming in and leaving much more quickly. So Melina, do you want to tell us about what you've built, which I think is a little bit better than what I have?
Yes, I had mentioned it before. You can create your smart phrases, any commonly used discharge instructions, come back to see the doctor when this and this and that. You were seen for such diagnosis, procedures. Some of that are usually standard. And usually when you're working inside of Epic, inside your AVS template is a dropdown. So all of that can be pre-translated. And then if you have, I don't know, the same procedure over and over, you can basically just have that smart phrases pre-translated and be done in a timely manner with a translator working on it and then reviewing it before it gets delivered to the patient. So smart phrases have to be translated, having a process in place so all the other interpreters and translators know how to use them and that they use them. Some of them can be stubborn and they want to use their own translation. You can work on that as well. And then you can provide that in a timely manner. We had about this process that I'm telling you about inside of Epic. We translated 4,500 AVSs. For those that don't know what AVS means, I'm sorry, because some of you don't work with Epic, is after visit summary. AVS after visit summary, which is a discharge instructions. And this is just purely for inpatient, okay? I'm not talking about outpatient services. We were able to translate 4,500 AVSs in 2023 in less than 20 minutes. Just because usually, I know, Debbie, because usually the
this
same...
whole, I just want to say, this feels very overwhelming as a language access manager. Like you're sitting here saying that you have all these smart phrases and you can do all this, but how, and we need to put a process in place for translators to know how to do this. But the thought of getting started with a project like this feels very daunting. So how do you make that easier for us?
You need, it's years. When I came to children's in 2015, I mean, the average was probably 40 minutes. And then you have to have a lean process, what's working, what's not. You have to have a group of physicians and who report to a medical director who says, hey, no more customized ABSs. It has to be the same. You know, it's a lot of work. And then the smart phrases, Julio, you're here. If you can please put it in the chat. How many smart phrases did you translate it? I think it's in the thousands. And then also train your staff. How do you access them and you go quickly through them? I do have a translator who can translate an ABS in 5 minutes. It's just crazy that she can do that. And so there you go. There's your timely matter. Now you cannot, now you don't have a clinical team saying it's because of the translation team that the patient didn't go home on time.
Mm-hmm.
So that
So,
was that.
so who are the stakeholders that you got involved when you just started developing your process?
I made friends with a person in Epic. Her name is Tanya. I can't remember her last name. And Julio's already sending me a meme. And another person who is the software developer inside of Epic that we just, and like, I think Vanessa had put it before, you just have to be persistent. You have to be after them. Maybe email them on a weekly basis. They're going to get sick of you and eventually get it done for you. And some people are walking around the hallways and they just use a different pathway. I'm just kidding.
And then Caleb, can you tell us about like Epic's workflow here around like smart text override, ABS templates, that sort of stuff?
Yeah. So I'll start with what's today and then a bit of something that we're working on as well. So today, in terms of the after visit summary structure overall, the goal is that nearly everything would be able to be translated statically ahead of time. So you have different types of information that can show up within an after visit summary, and that almost all of that, if you're working ahead to make sure things are prepared and translations are mapped appropriately, can be translated. But and then the patient instructions, like the educational materials that Melina had mentioned earlier, are the kind of those templated handouts that many vendors provide in multiple languages, and you can map those behind the scenes so that Epic will respect that patient preferred language and pull in the appropriate version of that education material. The current kind of challenge that we have that we're working to improve down the road is for those instructions that are written up specifically for that patient. And the project that we're working on is intended to provide a path to get a draft translation of that in front of a translator using machine translation, so that a translator can verify that and sign off on any edits that they've made. And then the after visit summary would be made available in MyChart, the patient portal, or be sent with a secure link to the patient over SMS or email later. So that's kind of the direction that we're heading, and trying to make sure that the things that can be done ahead of time are done, and then it can be supplemented by the things that are written up specifically for that patient and that given admission or encounter.
And we did the translation of 1,000 smart phrases. But I'm lucky that I do have a full-time translator working remotely just on these efforts, okay? Not everybody has the opportunity to have a full-time translator just working on these things. Actually, I have 2 now, but 1.5.
And how many languages are in the inpatient ABS? Is it you said there's 12 languages in Epic, right? So can all of those 12 languages be translated or more than that?
Caleb, wasn't it for MyChart only for the app, not for the inside ABS though?
Yeah, the after visit summary has 14 languages available, and that spans the outpatient or inpatient side of things. I know there are organizations that have said that their specific patient population needs additional languages, and they've done that translation work to provide the after visit summary into even more languages. So that 14 languages represents what Epic has available as part of our software, but organizations using Epic can expand on that.
Somebody's asking me, how do I track quality? How do I track the quality of the translations? I think that's a very important question. Like I said, the smart phrases have to be pre-translated. The translation was done by a ATA certified. I hope everybody knows what ATA certification, American Translator Association certified translator that I have in the team, and also reviewed by somebody else as well. We even have somebody proofread them. So that already provides quality on the translation. And then I have a group of people inside the team, 5 of them who do audits. Quarterly, they do audits. They pull ABSs from Epic, and then they make sure that interpreters who are allowed to translate are using the smart phrases and the quality is there. So we kind of do an audit inside the department.
Excellent. We have about 3 minutes left. So I just want to give each of our panelists an opportunity to have some closing remarks. I've been basically writing things down and trying to memorize everything everybody has said. There's just so much information that's shared here, and I'm really excited about having a part 2. So what would you like to leave us with as your final remarks on how to be successful with our EMR?
I think it depends on partnership. You got to build those partnerships within your organization, but work with your EMR vendor. Find out who else uses that EMR, who else is pushing the boundaries there on what can be done on language. You're not the only one with these challenges, and we can learn from each other and move much more quickly.
Excellent. And I keep saying EMR, you did too, so I don't feel so bad. But EMR, EHR, we use them interchangeably. So our electronic medical record, electronic health record. I'm sure you all know this by now. Rosemary?
I'd like to add that we talked about language and how important that is. My point about language is, you could recite the law all day, but that might not be your leadership's language that they speak. So think about using language that they may understand more in depth, such as patient experience, patient safety, quality of care, health equity, health disparities. Try those vocabulary words when you're trying to make changes within your program.
Speak their language. Absolutely. Great tip. Great. Melina. Oh, you're muted, Melina.
What was the question again?
Just any final parting words. We have just over a minute or so left. So anything you want to leave us with?
I'm going to be redundant. I'm going to be redundant. Grow your network and be persistent. You're going to get a lot of no's. Keep going and surround yourself with people that feel and have the same energy that you have when it comes to language access services, please.
Great. Thank you. And Caleb, last but not least, love to hear from you.
Yeah, I'll echo many of the same themes in terms of collaborating with your peers, but also working closely with your vendor. At Epic, we're especially interested in learning firsthand about your experience, and developers will come to our customers and actually observe for a day or two and see, how is this working? How is it not? How can we continue to make this easier for everyone and less costly and more efficient? And healthcare is a challenging space, but there's a big opportunity to treat people with dignity and respect and help them improve their well-being and health. And we can tackle that together.
Now I'm the one muted. Fantastic. Thank you so much. This has been so enlightening. I really appreciate spending the past 90 minutes with all of you. And I look forward to the next one. So thank you all for joining. Oh gosh, there's my timer. And we're done. Have a wonderful rest of the afternoon. Thank you so much, everybody, for joining.
Thank you, everybody.
Thank you.